high grade. He is having he falls into the high risk category. I would also like to look for an central line access for him and invasive pressure line
Okay.
for continuous blood pressure monitoring.
Okay.
Then his other systemic examination, like his respiratory system, whether he has any foreign sounds during respiration, whether his oxygen saturation is normal, and whether his peripheral pulses are good. Then
Okay.
other systems, let's get GI, he has any history of reflux in the GI system. That's it.
Yeah, you can just go ahead with like whatever the NP or what are the risk you will explain and all that. Like you just continue, like how would you anesthetize?
After evaluating for this, then I would like to explain the risk to the patient and the patient's relative regarding the surgery and his perioperative duration and his outcome. So would like to explain that he falls into the high risk category because of his cardiac condition, having comorbidities of hypertension and diabetes, which can superadd to the complications in the postoperative period. I would like to inform that there will be a possibility that we may have to give him blood transfusion if required, if there is a lot of blood loss. And he would require an invasive monitoring during the perioperative period. We would like to monitor him in a high dependency unit or a critical care setting in the post-operative period.
Okay.
So I would like to tell him regarding the conduct of anesthesia. I would prefer general anesthesia technique over regional anesthesia for this patient, and would explain the risk related to general anesthesia and the advantage over regional anesthesia.
What is the advantage of general anesthesia over regional anesthesia in this patient?
In this patient, because his valve area, he has aortic stenosis and there is a fixed cardiac output state, I would prefer general anesthesia over regional anesthesia because we do not want any hypotension for this patient, which is very common with regional anesthesia.
Okay. What is the cardiac grid which you like to maintain for a patient with aortic stenosis?
I didn't get you.
What is the cardiac, like how would you maintain the heart rate, contractility,
Okay, so for
SVR, PVR for this patient?
This is a patient who has a stenotic lesion. So I would like to maintain a near normal heart rate for him because it is a stenotic lesion. Because any tachycardia will increase the workload as well as the ventricular filling pressures, and also reduce will increase the myocardial oxygen demand. And because of the tachycardia, there may be decreased oxygen supply to the heart because of the decreased diastolic time. So, I would like to maintain a normal heart rate in this patient. I would like to maintain reduce the SVR to maintain a forward flow of blood.
Actually, in aortic stenosis, we usually maintain the SVR, neither decrease it nor increase it. Okay.
Maintain this.
Okay.
Then
contractility.
Contractility, I would like to maintain the contractility of the heart, reducing by I do not want to reduce the inotropic effect. So,
okay, you continue with the conductive anesthesia.
So I would prefer to give general anesthesia to this patient. Before starting anesthesia, I would like to put in the appropriate monitorings, like ECG, 5-lead ECG, then invasive blood pressure monitoring. I would like to put an arterial.
Just a second. No? So we have just explained the risk. We have not given orders for whether to continue the antihypertensives, whether to continue the anti-diabetic agents, and we have not given the NPO orders, pill per oral orders.
Okay.
Okay.
So I would like to tell the patient to maintain a NPO status of at least 6 hours of fasting prior to the procedure. To continue with all his medications, what he is on for his hypertension. If he is on any ACE inhibitors or angiotensin blocking agents, angiotensin 2 blocking agents, to stop them, to omit the morning dose prior to surgery.
Okay.
Continue with all other antihypertensive medications. He's on beta blockers, then he needs to continue his beta blockers. As far as diabetic medications are concerned, to omit all the oral hypoglycemic agents. If he's on insulin, then depending upon the HDT, to decide on to continue insulin as per the sliding scale.
Okay.
So can I proceed ahead?
Yeah.
I would like to reserve blood for this patient before starting the procedure. After taking the patient inside the OT, I would like to monitor this patient with appropriate monitors like the ECG, like an invasive blood pressure line, arterial line for to measure the blood pressure. I would like an access of central venous line for maintaining, for giving blood and blood products if required, and inotropic supports if required. Then I will keep the ETCO2 and gas analysis monitor ready for general anesthesia. I would take a good peripheral line for in case required. So I would go ahead with giving general anesthesia to this patient. So I will pre-oxygenate the patient with 100% oxygen, so that I'm supplying with good amount of oxygen. I will induce the patient with etomidate. I will give sedation to this patient to relieve his anxiety with benzodiazepines and some amount of short-acting opioids like fentanyl. Induce the patient with induction agent like etomidate.
Okay.
And or can I give options if or
you can just say like how you will go ahead. Like if they ask how will you anesthetize this patient, you say you see the theater, I'll check the boils as I routinely do, and I check for the emergency drugs in place, and I load the drugs so and so. And once when I shift the patient, I connect these monitors. And say in my exam, I just said whatever they asked. I say I just give 2 milligrams of midazolam. I will give 2 micrograms per kg of fentanyl, and I'll give propofol so much milligrams per kg. Provided if they give the weight, I'll just say how much I will give. Else, I just say what is the routine dose which we usually give. And sometimes the examiners are like, do you really do this? I mean, if they ask about, will you give this block? This is what, if you say what you have been routinely practicing, they don't question much.
okay.
So once when the patient is, because he's a cardiac patient, you say I'll give titrated doses of etomidate so that the patient becomes under, and I'll just continue with trying to ventilate. And if I'm able to ventilate, you say you'll paralyze. Whether you will paralyze or whether you do it on spontaneous, it's your choice depending upon how you practice it.
So I would like to give etomidate in titrated doses so that the patient gets better, and I would like to paralyze the patient with injection vecuronium 0.1 milligram per kg body weight.
Okay.
And ventilate the patient. After 4 minutes of ventilation, I would like to intubate the patient with an appropriate side endotracheal tube.
Okay.
Then I would like to maintain the patient on oxygen air combination with sevoflurane in titrated doses to maintain his systolic and diastolic blood pressures, and maintaining adequate depth of anesthesia. For analgesics, I would like to give titrated doses of fentanyl as and when required. I would try to keep him normovolumic by giving adequate doses of balanced solution like ringalactate, and so.
So during intubation, we have not told about how will we abolish the stress response. And regarding pain, we need to be much more careful about saying it's a multimodal analgesia with opioids, paracetamol, or if the patient, not for this patient, but if the patient is young enough to give non-steroidal anti-inflammatory agents, you say like I'll give a non-steroidal anti-inflammatory agent. And prior to surgery, I give this regional block. So when whatever comes into that multimodal analgesia, you have to cover it as a whole, not just fentanyl doses.
Okay.
So stress response is very, very important in this patient. In this patient, ischemic heart disease patient, any cardiomyopathy patient, and a patient with valvular heart disease.
Okay.
So you say like I'll abolish the intubation stress. However you practice, maybe you will be giving Xylopar 2 milligram per kg or 1.5 milligram per kg. You can just say that and continue.
Okay. So I would like to avoid the stress response by giving IV dose of Xylopar, lignocaine, 1.5 milligrams per kg body weight, and then do the intubation.
Okay.
Before starting the anesthesia, I would like to give a regional block to like a fascia iliaca block for his pain relief.
Okay.
And I would like to give multimodal mode of anesthesia, analgesia, like injection paracetamol 1 gram IV, and fentanyl.
Okay. So some of the examiners may be very particular about monitoring these patients with 5-lead ECG. Okay, 5-lead ECG and urine output and temperature monitoring. Okay. Normovolemic, normothermic. Temperature also need to monitor. You can give forced air warmers. You can also commit that. We'll give the patient with forced air warmers. And if at all, no, some of the surgeons usually position the hand in such a way that it comes across the patient. So you can say, I'll secure the IV cannula or an arterial cannula in the opposite side to be more specific. Whatever we do routinely, that is what we do. No, we do secure the line in the dorsum of the hand of the ipsilateral side with the fracture. Give the arterial line on the opposite side of the fracture so that the arterial pulse become okay. Or else we keep the hand like this upon the patient, then it becomes difficult to monitor. Sometimes it gets kinks. No? So all these practical aspects which we do routinely, you can also commit.
Okay.
Okay. Okay. Yeah, through the surgery, we can continue.
So intraoperatively, I will monitor for the heart rate and maintain a normal heart rate between around 80 beats per minute. Line to maintain a normal systolic blood pressure and also diastolic blood pressure. Then ETCO, I will maintain a normal ETCO2 range.
Okay.
oxygenation of the patient by giving adequate oxygen, maintaining at least 40% of oxygenation. Then monitoring the urine output, the blood loss of the patient operatively. Then monitoring the temperature and maintaining normothermia by giving warm air blankets.
So intraoperatively, as and when the surgery is going on, the ECG just had an ST segment depression and the vitals are stable. So how will we proceed?
The patient has
ST segment depression. Only purely ST segment. There is a new onset ST segment depression in the intraoperative period. And how do we proceed?
So if there is an ST segment depression, I would like to correct to find out the cause for it. Deepen the depth of anesthesia, give adequate analgesics to relieve any pain, or then deepen the depth to take care of any awareness. If the blood pressure, try to maintain a normal blood pressure of the patient. Provide with oxygenation, proper oxygenation, and increase the FiO2. And maintain normocapnia. Then, in spite of this, if the ECG changes are not reverting, would like to give
yes, segment depression in any perioperative period can be because of a myocardial injury, and all you have addressed, like you said, you will maintain normothermia, normocapnia, blood pressures to be normal, ensuring adequate depth and pain and anemia. So if at all you correct all these, and if it settles, it is okay. If not, it is a perioperative myocardial injury, and postoperatively you can get a cardiologist review for the same. And if the drop is elevated, and protocols for goal-directed therapy can be done for any patient who will have a perioperative myocardial infarction or a myocardial injury. Okay. Okay.
At this point, if the patient develops ECG changes, do we need to talk about giving nitroglycerin?
Not necessarily. If there is any hemodynamic perturbations regarding the same, if there is hypertension, then you can commit. Else, perioperatively, if the vitals are stable, we can just consider it as a myocardial injury and go ahead. We do not give them like statins or anything or so. If under general anesthesia, anyway, whatever we are providing are vasodilators only. If you can commit, there is nothing wrong in committing, you will use a low dose NTG.
Okay.
Okay. So regarding the postoperative period,
once the surgery is done, I would like to stop all the inhalational agents and increase the oxygen flow to 100%. Once the patient starts breathing spontaneously and is awake, I would like to extubate the patient. During extubation also, I would consider taking care of the stress response to avoid any stress response. So I would like to give lignocaine 1.25 milligram per kg.
okay.
Extubation, but I would like to extubate the patient awake.
Okay.
Then after the extubation, patient is maintaining airway, would supplement the patient with adequate amount of oxygen, either by with a nasal cannula at 2 liters per minute. Try to find out if he has any pain in the post procedure, and if he has, then I would like to give fentanyl 2 micrograms per kg in titrated doses to his pain. And I would like to give tramadol 50 milligram IV slowly to take care of his pain.
Okay.
Then I would shift the patient to a high dependency unit where he would be monitored for his ECG, pulse oximetry, and blood pressure. In which the blood pressure, I can do a CBP monitoring if required. Monitoring of his urine output, maintaining normothermia in the post-operative period, and avoiding shivering. Like to maintain his normovolemia with IV fluids that we elected.
Okay. So one of you has asked about giving a regional in severe AS. I will not commit answer of regional in this patient for because having a critical stenosis and a severe gradient. There are practical possibilities of doing it under titrated epidural or with the spinal catheters, where even in our group, Robert sir has shown to those drugs to act in a miraculous way. But what I practice is what I will always tell. I will always go ahead with general anesthesia. And sometimes in these high risk patients, to avoid the stress response, even I usually give them a supraglottic airway. And whether I paralyze or not depend upon the patient, how they are reacting or how their lungs were preoperatively. So you can always say, I'll give a supraglottic airway and then take it out at the end of the surgery. It doesn't make any great difference. But then if the patient has got a gastroesophageal reflux disease, or if it's going to be a laparoscopic surgery for this patient, then I will not commit supraglottic airway. Supraglottic airway, then I will actually say I will go ahead with the intubation rather than a supraglottic airway. If the patient remains under continuous respiration and it's a complicated surgery which will take. So if the patient remains unstable, then it becomes if it's a complicated surgery, you ask the surgeon to finish. If they ask, there is a question, Minoti ma'am, from the from one of the participants. If the patient remains unstable and there is a continuous ST segment depression, despite of all efforts intraoperatively, and it's a complicated surgery which will take time, what will be the management? So ST segment depression alone, if it is there, then we can ask to send a tropi. Okay. So when we send a tropi, if it is positive with the ECG change, you can actually go ahead and say it's a perioperative myocardial infarction. If the patient is remaining unstable, you can start them on noradrenaline doses of infusion. And if it is possible to see for an echocardiogram, since you're saying it's a complicated surgery, you can always say, if it's possible to get a TEE on place, I'll do a TEE, or if I'm able to do a TTE, I'll do a TTE and find out if there is any new regional wall motion abnormalities. Depending upon how the patient presents, if you are able to give inotrope and push the patient through surgery, you can push it through inotropes and vasopressors. If you should ask your surgeon to finish the surgery faster and inform about a perioperative myocardial infarction. And you can always say, I'll inform the attenders about the same, and all those scenarios which you will do it routinely. If you are able to finish it and if the patient is able to pull through, then it's fine. If not, depending upon the benefit versus the risk ratio of bleeding versus the thrombosis which has already happened, maybe the patient needs to undergo a CAG.
Okay. But regarding tropi, the tropi levels take some time to become positive. So if it's a fresh infarct, sending tropi or drop T.
So, her question was, if it's for a very long time complicated surgery, if it's continuingly, like she's asking for, if it's continuing for 2 to 3 hours, the ST segment depression itself. I mean, that is what is the question for. Despite there is a continuous SPD, so if you send sample at 2 hours or 3 hours, then it's supposed to be positive, right? So once when it has started at 2 or 2.5 hours, if you send, and if it's become positive, then you send a repeat sample again after 6 hours, and if it's again on the increasing trend, and then you are sure about, like we can take Whipple's for example. it's a complicated surgery which is going to take for long. And in some centers, they even do it for 12 hours. In such cases, a scenario, you can stay the surgeon, the patient is developing a perioperative MI. So also perioperative MI is of two types. One is an ST segment elevation and another one is a depression. So both have got very different modalities. Segment depression is usually a demand supply mismatch, wherein you can treat with whatever you have addressed, ma'am, like pulse rate, blood pressure, depth of anesthesia, pain, anemia, all that. And a rapid occlusion with the plug rupture usually leads to this kind of scenarios. And I have discussed in my earlier class also, any patient who is above 65 years of age with the cardiovascular history, do a preoperative troponin. You can commit. Any patient more than 45 years of age with known comorbid illness of ischemic heart disease, do a tropi preoperatively. Okay. And do a troponin at 48 hours and find out if there is a troponin rise. If it's a troponin rise, it is myocardial injury following on cardiac surgery, and treat accordingly, get a cardiac opinion. In this case, the patient will be sent to ICU or CCU. So this patient will be sent to CCU, cardiac care unit only. Okay. If cardiac care unit is available, the patient can very well be sent to cardiac care unit as well. Okay.
Okay.
Okay. So anyone up for the next question, which is about a hype? Why am I? Just a second. I'm hearing whatever I spoke. Okay. Anyone else up for the next question, which is about a hypertrophic cardiac myopathy? Someone can just try it, right?
Hello.
Yeah.
I can try. I have not revised it for a long time, but I can.
No problem. No problem. No problem.
Yes, please, madam.
Yeah, this is the question. You're asked to anesthetize a 25-year-old male patient who had history of frequent syncopes and evaluated to have a hypertrophic cardiomyopathy. He is posted for an emergency obstructed inguinal hernia for laparotomy and proceed. So how will you evaluate this patient and how will you proceed? Okay. Anyone up for what are the types of cardiomyopathy which we know of?
Yeah. Can I?
Yes.
Cardiomyopathy can be classified into 5 types.
Yeah.
There's hypertensive, hypertrophic cardiomyopathy.
Yes.
And there's dilated cardiomyopathy. There's restrictive cardiomyopathy.
Okay.
Arrhythmogenic ventricular cardiomyopathy. One is LV
non-compaction. Okay.
So
Yes, sir.
I would like to. I would take his history of effort tolerance, starting from his childhood.
Okay.
Any history of syncopes, any history of chest pain, any history of breathlessness on effort, and would look at the I'm not able to articulate as an answer, but like hypertrophic cardiomyopathy, it causes there's an increase in the thickness of the left ventricular wall and septum, and there's obstruction to outflow.
Okay.
Besides, the hypertrophic cardio muscles are not able to get enough oxygen through normal coronary arteries, and despite coronary arteries being normal, the patients have signs and symptoms of ischemic heart disease.
Okay.
Usually they do not tolerate effort and they have a tendency to suffer a syncope if they
Okay.
try.
Okay.
Idea is to keep the ventricle full, left ventricle full, and heart rate low
Okay.
to decrease to oxygen consumption and maintain sinus rhythm.
Okay. How will you maintain the
Peripheral
contractility?
vasodilatation, peripheral vascular resistance should be kept high.
Okay. Okay. How will you maintain the contractility then?
Yes, contractility by inotropic agents if required.
No.
No.
See, in
Well,
all
that will rather
all
obstruct
these
it more.
cardiac disease patients, no, we have to have a particular set. We have to have a cardiac grid in our mind. If it is aortic stenosis, say you will maintain a low sinus rhythm rate of 60 to 80, maintain contractility, maintain SPR, do not allow an increase in PVR. If it is a hypertrophic cardiomyopathy, you say you will maintain a low heart rate, you will decrease the contractility because it is already hypertrophic and hypercontractile. And if EF in this patients will be somewhere around 70, so they are hypercontractile, and you need to decrease the contractility by using an inhalation agent or whatever. So if you only place where in a cardiac patient we'll say we'll decrease the contractility is hypertrophic obstructive cardiomyopathy. And whenever these patients come, you say, this patient I've already given him as a patient who has got an obstructed inguinal hernia posted for an emergency repair. So whenever you say how will you proceed, you say what are the history I'll take, what is the symptom for which he had presented for the inguinal hernia, whether he had vomiting, whether he had abdominal distension, how is his fluid status right now, because these patients do not tolerate a decrease in preload. So how will you optimize the patient preoperatively even before taking up the patient for the surgery? So you say, like, I'll see the patient, ask his presenting complaints, ask about how did he diagnose to have a hypertrophic obstructive cardiomyopathy. Since he had a frequent syncope, ask if any of the family relatives have got a frequent syncope. So recurrent syncope increases the risk of sudden cardiac death as well in hypertrophic obstructive cardiomyopathy. So evaluate the patient for airway. You see for the pulse rate, blood pressure, temperature, respiration, check for chest x-ray, check for normal CBC, all that you complete. See if the patient, since it's an emergency surgery, you have to do it as an emergency, but still check for the NILPER oral guidelines. Get them a high risk consent of saying there is always a possibility of sudden cardiac death, and this surgery in him is a very high risk surgery. Explain the relatives to that, and you say you will secure 2 wide gauge lines and also an arterial line, since it's a high risk surgery, because it's a laparotomy and proceed, and the patient might have got a third spacing because it's an obstructed hernia, no? So third spacing might have happened. So I'll go for an arterial line or a central line, and you proceed as if you will do it. You need not. What mistake we'll do is we'll always keep our mind focused on hypertrophic obstructive cardiomyopathy, and we always tend to forget about our routines. The same happened right now, so I think. So so you say I'll evaluate preoperatively what all you will do regularly. You say that, and then only go and say these are the perioperative things I want to look on. So this hypertrophic obstructive cardiomyopathy is like non-obstructive, latent phase, and obstructive. If the gradient is there more than 30 millimeters of mercury at rest, then it is an obstructive type. Only when exercise is happening, if the gradient is rising, then it is a latent type. And even at rest or whatever, if it is not rising more than 30 millimeters of mercury, it is non-obstructive. In these patients, we also have that there is hypercontractility. There is also a diastolic dysfunction, and also systolic anterior motion of mitral leaflet. Whenever that happens, our role is to increase the preload. So once when we increase the preload, And in echo, I have given only the patient has got hypertrophic obstructive cardiomyopathy. I have not said anything about the valve gradient. I have not mentioned if the patient is obstructive or non-obstructive. So you also have to say, in the echocardiogram, I will look for if it's obstructive or non-obstructive and what is the gradient, if the patient has got a systolic anterior motion of mitral leaflet or not. And you see for any ECG, if you take, some patients might have a hypertrophic change as well. And you say you will optimize the patient with fluid resuscitation or whatever resuscitation, give them antibiotics since it's an obstructive type. All that you say, and then only you say, I'll induce the patient with so and so, so and so. Provided the patient is stable, I'll give him midazolam. I'll give him, I'll give a Riles tube preoperatively to decompress the stomach. All that must come in place. Whatever we do routinely, it should come in place before even thinking of HOCM. Okay.
Fine, madam.
Yeah. Now, can you continue saying about only from the induction?
I haven't specifically read about it recently.
Barisha, ma'am, can you please answer? No, you have put everything in the group. I think you can come and answer.
Hello, ma'am.
Yeah.
Can you listen to me?
Yeah. Very well.
I haven't read it a lot, but I can give it a try.
Yeah, sure.
Intraoperatively?
From wherever you want to continue.
As you wish, ma'am.
No, from the assessment you just say.
Okay, as it is an emergency procedure, and they are going for a laparoscopic, they are going for an obstructive hernia, laparoscopic obstructive hernia. Okay, I will go for a history first, then clinical examination, then investigation, and so on. For history, I will go for a family history, whether as it is already diagnosed that he got an HOCM. So I will go for a family history, whether there is any family history of HOCM or anyone died within this with disease in this year, 20 to 25 years or in a young age. Whether he has any other congenital disease, because we know that HOCM is associated with some muscle disorder like ataxia, Friedreich ataxia, and yes, Friedreich ataxia. So if there is any muscular disorder or not, and if he has other cardiac disorder associated with HOCM like WPW syndrome, whether they know it or not. If not, then we will proceed for other history, like now we'll go for his symptoms, like why he's for how long he is suffering from this disease, the obstructive hernia. If there's any vomiting, there's any pain, acute pain. For pain, did he took any medication? Is there a pain in the abdomen? About his urine output and other stuff. And for HOCM, I would like to ask about when it was diagnosed and how it was diagnosed, what was his first symptoms, and whether a last cardiologist visit, what drugs he is taking for it. This is a history, and then I will go for clinical examination. The clinical examination include general examination, systemic examination, and general examination and systemic examination. For general examination, I would check his vitals like pulse, BP, temperature, anemia. Then for the dehydration, for systemic examination, I will give emphasis particularly to his precordium, because while examining his precordium, I can have some idea about his HOCM condition. Likewise, he could have a jerky pulse, and the apex beat will be double apex beat, and there might be systolic murmur during auscultation. Along with, we'll go for his respiratory examination, whether he is in failure or not, and then I will check his abdomen, where he felt tenderness, whether it is generalized or localized, and then I will go to check his dehydration status. I will ask for his paroral fluid and food intake, the last food intake, any allergy to any medication, drug, what drug history, what drug he is taking, any anti-arrhythmic drug he is taking or not for his HOSM. Then fast investigation like routine CBC, creatinine, electrolyte, blood glucose level, ECG, and obviously echo and chest X-ray, just to exclude any other associated lung or cardiac condition. I will inform the patient's guardian that it will be an high risk operation, as it will be, it's an emergency, it is in an emergency status, plus the patient got HOSM. So I will give an idea about the operation, the anesthesia, and postoperative management. We'll take an high risk consent, and we will confirm that he might need an postoperative observation for 24 to 48 hours in the either in ICU or in CCU under cardiologist, under one of the cardiologist supervision, of course. And also I will call and inform a cardiologist regarding about the patient's condition, and will take any consultation or advice if necessary. And then we will approach for the approach intraoperatively. For this patient, I need 2 large bore cannula, bit to bit monitoring of the blood pressure. So I need intra-arterial line. A CVP line is I will recommend, because as we can see that we can have a large airwave. We can see a large airwave through the CV line, and temperature monitoring, and meticulous giving a meticulous fluid management, because this patient have left ventricular dysfunction, left ventricular outflow obstruction. So we should be very much careful about fluid management. And if there is, we should keep some emergency drug ready. Likewise, like inotrop, for continuous inotropes, we will keep some syringe pump ready, along with some antiarrhythmic drug like amiodarone.
Ma'am, you said about you want to load some vasopressors or inotropes. Which do you prefer?
Actually, in this case, I would like to do a NORAD.
Okay. Okay.
And I would these are the things I would inform my OT staff and my helper or technician to just keep it ready, or I will keep it ready also. And for induction, I will choose and choose some agent that will not put the patient into hypotensive condition, too much hypotensive condition. So I will go for a smooth induction. I will not switch on for a sympathetic intervention or sympathetic outflow. So first of all, I will like to start with midazolam and remifentanil. I will prefer for the opioid, fentanyl or remifentanil. Then I will go for propofol, and for muscle relaxant, I will go for non-depolarizing rocuronium or vecuronium if there is available. And for maintenance for volatile, I will go for sevoflurane and air with oxygen. I will try to avoid the nitrous. And I would and obviously I would do a fluid management meticulously, because as I have said that they have a left ventricular dysfunction. So I will be very careful during fluid management. And
dysfunction in this patient is a diastolic dysfunction, not a systolic dysfunction. Is that okay? So in these patients have got a diastolic dysfunction, and for their hypertrophic cardiomyopathy, we need to give fluids. But if the diastolic dysfunction is severe, then we need to be very cautious with fluids. So it's a double-edged sword to give fluid versus diuretics in these patients. And we have to very carefully assess them, as you told. So if there is hypotension with tachycardia, then we may have to consider giving fluid at that stage and treat it with either phenylephrine or norepinephrine, and ephedrine, dopamine, dobutamine are contraindicated in these patients. Okay, so if you actually have, if it is a high risk surgery, you can also say we can have a TE, we want to have a TE in place, wherein you can actually see if there is systolic anterior motion or an obstruction which is causing that pathology. If it's obstruction, you can very well go and give fluids. If there is systolic anterior motion, you can give fluids and you can give phenylephrine and treat. But then if you assess, there is no systolic anterior motion, there is no obstruction, but then the patient is hypotensing and he's developing lung signs, means it is diastolic dysfunction induced pulmonary edema, and that time you need to curtail the fluids. If it's a high risk surgery, you can commit it. Say, I'll have a TE in place. Since he is a high risk patient, I'll have a TE in place. Look if there is an obstruction. If it's an obstruction, or obstruction, by obstruction I mean is a systolic anterior motion of the mitral leaflet. If there is SAM is systolic anterior motion. If there is systolic anterior motion, you say I'll give fluids because preload is less. So I have induced and I have initiated a positive pressure ventilation. Positive pressure ventilation itself will decrease the preload. So in these patients, a low tidal volume with the generous amount of respiratory rate ventilation is what is preferred. So since I have initiated a positive pressure ventilation, maybe decrease in preload is the cause, which I can rule out by doing, if it's an invasive surgery or so, TE will be helpful. I'll look for a TE and find out what is causing his hypotension. If it is obstruction, you say I'll give fluids by which a systolic anterior motion can be mitigated. Give beta blockers once when the BP settles. If there is a persistent elevation in heart rate in such patients, you can very well commit, say, I'll give beta blockers.
Beta blocker,
Okay. So we can go for an extra agent. Say I'll make use of a TE in these patients. If you get a high risk patient, posted for an emergency surgery, emergency high risk surgery. Here I've given an inguinal surgery, but then I've given it as an obstruction. Also, whenever any obstructive pathology in the gut is given, we always have to mention I'll decompress the stomach or the abdomen with the Riles tube prior to induction.
Okay.
And you say, depending upon the NILPER oral guidelines, you say whether you will give a rapid sequence induction or if it's a routine induction, because you have committed it as vecuronium because he's a cardiac patient.
Yes.
I can understand you did so because he's a cardiac patient, but then he's also not NILPER oral because it's an emergency surgery. So you have to see, you have to mention here as an RSI, no, because
yes, madam. So, I understand.
So you just have to, I'm just saying, also look for if you have to say about a rapid sequence induction because it's an emergency surgery. So you may also get a situation wherein you are given a situation of around I think you can try this probably now. You are given a situation wherein the patient is a 29-year-old primey who has got a severe mitral stenosis, posted for an emergency lower segment cesarean section because of a fetal indication. How will you proceed? Past time, I started some 5 minutes past time only. I think you can have this also in place so that you will have a practice.
So it's the priming
29 years old primey, severe mitral stenosis, posted for emergency cesarean section because of a fetal bradycardia, which is the indication.
Okay, fine. As the patient there are two concerns that the patient is pregnant, or along with there are two lives here, and along with the patient is suffering from MS, and the third is the emergency CS. So I will keep in mind that I will have to be very conscious about these patients, and in this case I will take a very short history regarding patients, any surgical or anesthetic history before, any consequences during surgery, or any what kind of anesthesia she has taken, any other medical condition for which she was admitted in a hospital, for any acute case or any acute cause. If not, then I will go for an examination, the general examination and systemic examination. General examination include I will go for an anemia first, because the MS patient usually have as MS patient along with pregnancy, they may have an anemia. So I will rule out any sign of anemia, is there is any anemia or not. Then the pulse, blood pressure, temperature, last intake of oral and or the food intake, and then I will go for systemic examination. I will check very rapidly to the precordium and respiratory. I will give to these two systems, give emphasis to these two systems, especially for this patient. The precordium, I will check for the if there is any visible, audible murmurs is there, and if there it is and second, if there is any sign of failure or not, whether there's any crepitation or there bibasal crepes. The respiratory, I will check for her respiratory rate, whether she is in tachypneic or not. Then I will proceed for investigation, which is include the routine investigation, the CBC, creatinine, blood glucose level, and short ECG, no chest X-ray for this patient as she is pregnant. And if possible, I will go for if possible and there is any time, I will go for an echo. And the next thing that I will tell the patient's guardian that it will be an high risk surgery as she is in severe MS, and she could the fetal's condition, fetal has a bradycardia also, so she might have might need an supervision for 24-48 hours in the ICU or possibly CCU. And I would also call and inform an cardiologist about the patient's recent condition and take some advice if necessary. I will keep my OT ready, along with and short history of drug and allergy, of course, and keep my OT ready, including I need a double bore cannula, wide bore cannula, two in two hands, and intra-arterial line if possible, and inotrope support.
Will you go for regional anesthesia in this patient? Will you give spinal in this patient?
No, I will go for if the patient is in, as you said, is severe MS. So
Okay.
the patient might be in a failure state. So in this case, I will not go for a regional. If the patient's vitals is stable, I will go for regional. If the patient's vital is not stable, I will not go for regional. I will go for general anesthesia.
What type of regional anesthesia do you prefer in this patient if the patient is hemodynamically stable?
Intrathecal block along with lignocaine and lignocaine only.
So, ma'am, do you regularly use intrathecal lignocaine for cesarean section?
Sorry, it was a slip of tongue. I'm sorry. Intrathecal block booping.
Okay. Maybe some of them really use lignocaine, but then I have not personally used, so I just wanted to know what is the practice.
No. It was a slip of tongue. I'm really sorry.
Okay, so if at all, if I were to commit, I will actually say I'll give a graded epidural rather than a single shot intrathecal, because once when the SVR falls, if you commit and say you will give 2 ml, once when the SVR falls for a critical MS, then it becomes a chaotic scenario. SVR falls, there is hypotension, there will be compensatory tachycardia. When there is tachycardia, then filling will not be there. There will not be any forward flow. Then the pulmonary congestion may happen. If I were to say an answer, if provided, I'll say it's a graded epidural. I'll give some 3 ml aliquots of 0.5% bupivacaine, wait for the response to come. I'll wait for 10-15 minutes and then give the next dose as again a top-up dose, and then do it if they ask. Okay. So I would say refrain yourself from committing a single shot spinal anesthesia for a severe MS. Okay. And it is also, I mentioned it's a fetal indication, fetal bradycardia. So here the time for epidural and waiting for 15 to 30 minutes does not come into play. So if the scenario is given as an emergency LSCS, I would preferably say it's a general anesthesia rather than a spinal anesthesia or a graded epidural anesthesia.
Yes.
So the indication is a fetal indication here.
Yes.
So it's an emergency and the mother has got comorbids as well. So better to say it is a general anesthesia rather than epidural because or spinal, because here the scenario is totally different. It's a fetal indication.
Yes.
I think I'm making sense here. Okay.
Yes, of course,
okay.
of course.
Okay.
I will go for the general. Actually, I will making a general anesthesia scenario. Actually.
Yeah. But then
later on
in the examination, they'll never let you to complete a scenario. When you say no, whenever you say this answer, they'll stop you in between and ask questions like how I ask.
Okay.
Yeah, you may be right or wrong, but then that doesn't mean anything. They'll say the start of the examination only. You being right or wrong is not the point. They just stop that question, ask the next question, and keep on going like that. Okay. Yeah. So if you were to give general anesthesia, what are the steps which you would follow for this patient?
Okay. For general anesthesia, as I was saying that it's an emergency plus it's a high risk patient. I will go for 2 large bore cannula, intraarterial line if possible, and I will keep some emergency drug ready. Likewise, inotropes for this patient. I will go for NORAD or adrenaline. Then if the patient falls very rapid or too much, or initially I can give an ephedrine. I can give an ephedrine and
phenylephrine over ephedrine in patients who do not tolerate the heart rate rise well.
Phenylephrine.
Okay.
Yeah. And very much I will be very much careful regarding fluid management, because this patient cannot tolerate the heart cannot tolerate extra fluid and the contractility. So I will be very much conscious about the fluid management, as well as I can, if the patient is in failure, I can use an intraoperative diuretics. And patient, obviously this patient needs an catheterization because I need to see the fluid output, the urine output for my fluid management, whether if the patient is in failure or not. And for induction agent, and is as it is emergency, along with the patient is pregnant, so there is a chance of aspiration. So I would go for an RSI technique in this case. Before that, I will give an H2 blocker and prokinetic drug just to remove the just to ensure that the content of the fluid doesn't come of the stomach doesn't come out. And I will explain to the patient that what I'm going to do, what is RSI, and what I'm going to do. That I'm just going to press his throat firmly, very firm pressing while I'm giving the drug, and while she will be in a mild sleep. So I will release the pressure when the tube once intubated. So after explaining, I will go for induction. Will as it is an RSI technique, I will go for an RSI technique. Obviously need an second person's help. It could be my colleague or it could be an helping hand or technician. So I will ask the technician just to press the cricut, give a cricut pressure when it is necessary, when all the drugs is given to this patient. For drug choice for induction agent, I will choose I will avoid those drug which will passes through the placenta barrier and go to the baby and causes depression of the baby again. So I will like to avoid the benzodiazepine and opioid drug initially. I will try to induce the patient with volatile substance, and that is sevoflurane or sevoflurane. I will prefer sevoflurane along with propofol and mass relaxant rocuronium or becuronium if possible. Sorry, as I'm going for RSI, I will go for saxam. I'm really sorry. I will go for saxamethonium. Then after intubation, after smooth intubation, I will and connect the tube with the circuit, and when I will see that they confirm that there is an ventilation in the and see the wave in the EtCO2, then I will secure the tube and I will ask the surgeon to proceed. And meanwhile, I will monitor the patient all the vitals and avoid hypoxia, hypercarbia.
Suppose when you are intubating, the heart rate rose somewhere around to 140 and the BP somewhere shot up to 180 by 110. How will you manage?
In this case, I can give I can give an intravenous lignocaine and
you gave, but then again the pulse rate somewhere around was 130 and the BP is still rocking at 170 by 110 or so for around 5 minutes until they make the incision. How you can manage?
In this case, I can give a blocker.
Pardon me?
I can. Sorry, ma'am. I think.
Yeah, it's intravenous beta blocker.
Yeah.
Okay, it's intravenous beta blocker always. So you can either say if you have got hands on esmolol, it's esmolol or it's metoprolol. And if both of them are not available, then I can obviously say I'll give a titrated dose of labetalol. So when this patient has got a chance of decompensation into developing a pulmonary edema, what is the when will you expect that the patient may develop a pulmonary edema?
Okay, in this case, there will be, if the patient is developing pulmonary edema and there is an sudden deterioration.
When do the patient actually, throughout the intraoperative period, what is the most important stage at which the patients may land up in pulmonary edema?
Extubation.
After delivery of the placenta.
After delivery of the placenta, once when the cord is clamped, there is rapid rush of fluid into the maternal system. So the preload is suddenly increased after the clamping of the cords, and when when the baby, after the baby is delivered, so all comes into the same place. So that is when the patient will decompensate. So once if you feel that the rate, usually the heart rate will rise if the preload is increasing. So that time, if the heart rate is rising and if the patient is actually in the verge of desaturation, or if the patient is showing signs of pulmonary edema, we can then give a shot of Lasix at that point of time.
Okay.
Okay. Okay.
Okay.
So, okay. Yeah. And be very careful about committing propofol in the induction agent for this patient.
Okay. Yeah.
Okay, so some of them do use it because in titrated doses they do still use it, but then if you commit etomidate, they may not ask further into that question.
Okay.
Okay. Okay. How will you provide prime relief for this patient?
Pardon, ma'am?
pain relief.
Pain relief. I'm sorry. Okay. I can go for a multimodal analgesia for this patient. I can give an intraoperative paracetamol IV 15 milligram per kg body weight, or along with an diclofenac suppository, stat, and 8 hourly so on. I can also give a paracetamol 8 hourly post-operatively, and as I have said that I'm not using an opioid during induction for just to avoid further fetal bradycardia, but I can give an pethidine IM. I can provide an pethidine IM for post-operatively in this for this case, and also I can give an tab block after when the operation is finished. I can give ultrasonogram guided tab block.
You can still give fentanyl after delivery of the baby.
Yes.
Yeah. Okay. So yeah, someone committed tab block. Yes, tab block can be given. QL has also been tried. So there are lots of studies which has QL or which has tab. So whichever you follow locally, you just say you will just do it. Or some guidelines also say giving intrathecal morphine. So you can commit like whichever you want, whichever you practice, so that you won't miss it at all. So we routinely give bilateral tab. Some routinely give intrathecal morphine, and that takes care of the pain. So whichever you use, say it as a multimodal, as you have said just right now. Okay. So anybody knows the classification of severity of mitral stenosis, severity of aortic stenosis?
Can I?
Yeah, please. I'm running past time. Is it okay for all of you?
I'm okay.
Yeah. If it's okay, you can continue, ma'am. Classification of aortic stenosis grading.
Aortic stenosis, normal valve size is around 3 centimeters.
Okay.
Anything between mild stenosis is till 2.5. Moderate is 1.8 to 2.5. No. Severe is till 0.8. Critical is 0.6.
Okay. Come again for the moderate stenosis, which you told?
I think it is 0.8 to 1.5.
0.8 to 1.2 is moderate, and anything between 0.6 to 0.8 is significant stenosis, and less than 0.6 is critical. Okay. For mitral stenosis?
Mitral stenosis, normal valve area is around 4 to 6 centimeters square.
Okay.
Less than 2 is mild.
Okay.
1.5 to
1 to 1.5 is moderate.
0.5 is moderate. Then less than 1 is severe, and less than 0.8 is critical.
Okay. Can you tell about transmitral gradient according to mild, moderate, and severe?
Transmitral, I don't know.
Less than 5 millimeters is mild. 5 to 10 millimeters is moderate. More than 10 millimeter, the gradient more than 10 millimeter is severe. So less than 5 is mild, 5 to 10 is moderate, more than 10 is severe. Okay. So in aortic also, the mean gradient across the valve, mild, moderate, severe. Anything less than 20 is mild, 20 to 40 is moderate, more than 40 is severe.
More than 50 is critical.
Yeah. Okay. So only these things they may ask. So in case if the patient is coming for valvular heart disease with valvular heart disease, which I mean is this aortic stenosis or mitral stenosis with pregnancy in the mid trimester for any surgery, like you can just say as you have just told now with stress attenuation and all that. And if it is a very critical scenario, they may ask about balloon mitral valvuloplasty in the mid trimester or so, if you are getting a dire situation like that. So that scenario also you can just go through if you have time, ample amount of time. But routinely, this emergency management. And whenever it comes to that exam, what I personally felt was you see the patient as a whole and not just to that particular scenario. I had a scenario wherein they gave me for the ICU session a patient post uretrosigmoidostomy who's coming for ICU for breathlessness. And I attended the least for that uretrosigmoidostomy for that bladder carcinoma. I said evaluated the patient as a whole. I think that is what they are expecting. You don't see that particular thing. You see the patient as a whole, as you will see for all patients. Okay.
I just want
Yeah, sorry.
Yeah.
I have a question, ma'am, regarding this pregnant patient with a valvular heart disease, regarding the induction. So, Dr. Barisha, when she said we can use scoline, so generally the severe MS patients have atrial fibrillation sometimes. So, is it advised to give scoline for rapid sequence induction to these patients? And also regarding etomidate, just a question that etomidate is known to be teratogenic. So, is it advised?
You are giving it for emergency LSCS only, no? The baby is already,
Right.
I mean, they are about to deliver it. So that doesn't come into play. We can still say etomidate for an emergency delivery and also I wanted to make this point. Whenever the patient is coming for an emergency LSCS, no, you say you will ask the surgeon to drape the patient and finish all the sorts of draping. Once when the surgeon is ready, you will induce. So this is what we do routinely, no? So once when the surgeon is ready, you can induce. And regarding scoline, we have still given scoline in patients with severe MS. If you're so concerned, you can say it as I'll use rocuronium for induction, rapid sequence induction.
Can we say thiopentone and rocuronium along with the cricket?
Yeah, means sleeping dose of thiopentone, yes.
Okay. Yeah.
Yes, sleeping dose of thiopentone and I'll give rocuronium, yes.
Yeah, thank you, ma'am. Thank you.
Okay. And if they ask if the patient develops AF in the intraoperative period, we can say, depending upon if the patient is stable or not, I'll give amiodarone or go for a cardioversion. Since it's an acute one, no? If that a rapid answer, you can say, I'll go for amiodarone or I'll go for cardioversion if the patient is unstable.
Okay. All right.
Okay. Meenakshi ma'am, you were asked something.
do we need to memorize the different scoring systems like the Goldman's?
Yes, definitely yes. They'll ask this in the 4th session. They have questions for ICU. I told scenario, no? The patient came breathless after an ureterosigmoidoscopy in the postoperative period. What will you do? That was the scenario. After discussion of the scenario, the second part, the 4th part was actually divided into 4 parts. The second part was they asked me about SOFA, Q-SOFA, Apache. What are all the only the components of it? Okay. And what are all the cardiac risk scoring index do I know? I said about Detsky, Goldman, RCRI, and what else did I say? When I was finishing this RCRI, they asked me about, do you know about ASA? ASA also we should know, and you know about SOFA, Q-SOFA, Apache scoring for sure. ICU scoring systems and anesthesia scoring systems, they will definitely ask. Okay. Yes.
Are we expected to know all the variables of Goldman's and Eagle's Detsky's?
So when Goldman, yes, definitely yes. Goldman, yes. RCRI, okay. Yes. ASA, yes. And Apache, you just say it includes so and so. Q-SOFA, you say this includes respiratory rate, systolic blood pressure, like that. Only the components of it and what weightage it carries, it is not of any importance. For RCRI, you say each carries each point, and you mug that up for the table with the RCRI. No other go. And it carries weightage. This scoring systems and I answered everything, whatever they asked. No, they asked about GCS. They asked about GCS. All the scoring systems I answered. Then they asked what is AVPU. I was clueless, to be frank. It is alert, answering to verbal response to pain, unresponsive. I read everything. Then I didn't say this one in that exam. AVPU scale. This also they asked. You answered AVPU. What the examiner said, you answered all these, no? Answer this, he said. AVPU scale.
I think, ma'am, in UK, AVPU is very much used rather than in the emergency case.
I read, Barisha, believe me, I've read, but then when I was, the examiner was like, you don't know this, but then you answered about Goldman.
They use it every day in every emergency case. In AVPU, they use it every day, everywhere.
Yeah, that is alert. The patient is to verbal response, the patient responds, and to pain, the patient responds, and the patient is unresponsive. That is AVPU scale. And they asked about how will you see for GCS. So see, all this happens in 25 minutes. You won't believe how many questions you were asked in that 25 minutes. To write that down only, you'll feel like, oh, I answered these many questions. So GCS, they'll ask about what if the patient is intubated? What if the patient is not able to see? What if the patient's eye is injured? All that they may ask. So you say you will write as verbal response. Verbal response is T, then the patient is tubed. Please do not skip this part and go for the examination. And for the, chest X-ray and all that, go for that master pass and read how will you systematically view that X-ray. I was asked about, so we may not really get that same question, but if you get and if you have read it, it's an advantage for us. Master, how will you systematically analyze this X-ray? Just tell me is what I was asked for the first X-ray, and the second X-ray was pneumothorax, I think, which I'm not wrong. I mean, I'm not sure. I forgot. So what is the diagnosis? No. I was asked about pleural effusion, not pneumothorax. It was a pneumonic effusion, which was the question for me. They first asked to systematically analyze and then say what is the diagnosis.
Okay.
So one of the next colleague, he was not asked about how will you systematically analyze. He said he was just asked about see what is this patient has got. So, but if you are okay with how the master pass has approached that particular patient, then you will actually get through much more easily. If you were asked that particular question. Okay.
Okay.
Shall we close the session right now?
Ma'am, is a request. Can we have more classes regarding ICU cases?
Yeah, I'll make sure. One of us will make sure that ICU cases is what you want to ask.
Thank you, ma'am.
Okay, I'll make sure we get to do it, ma'am.
Thank
you.
Can you just let us know what are the ICU topics that you're aware of?
Okay, I'll post it in the group. Okay. Thank you all.
Thank you, ma'am.